One of the big things is intensive care specialists are very difficult to train, and you're stuck inside the little area that you are working because you've got so many sick patients. You can't just decide to leave your own ICU and travel out to another ICU. At the same time, people get sick at all times of day or night. So having a way of communicating quickly that this is the problem that you've got, and can you see any new aspects of the patient, or have you got any knowledge of new therapies that you can help the inexperienced medical officers with. So this is what we're trying to do effectively, act as a force multiplier to enable the influence of the critical care specialist to extend beyond the domain of his own ICU. In traditional e-health, where you are just relying on the story that you're told, if the story is incorrect, you have very little opportunity to correct it. So this is what we're trying to achieve with the bedside units.
Patients don't have to be transferred from the rural hospital. They can be treated closer to where they live, and the quality of service is not being compromised. That's the kind of value this project is adding to the department. This initiative is actually helping the specialists train the healthcare practitioners who are working in rural areas in difficult situations, especially when they have to manage very sick patients. A recording of a session, in case of a litigation later on, you can actually use this to defend ourselves.
A recording can become a valuable teaching tool, because we could then review back on it and perhaps just play back the recording to future young doctors who would be going out. When you go to this hospital, this is the kind of problem that you're going to encounter. Similarly, it would have those recordings will have a research component, because we could look at the effect of how our training program for junior doctors in a unit like Peter Maritzburg actually translates into effective care when the junior doctors go out to work as their community service officers in the more rural hospitals.
Hi, I'm Dr. Somasundram PILLAY. I'm a specialist physician employed at EDENDALE Hospital in Peter Maritzburg. My innovation involved setting up a multifaceted approach at EDENDALE Hospital in Peter Maritzburg to diabetes management. This multifaceted approach actually involved getting together a podiatrist, dietitian, getting a diabetic nurse educator, both clinician and nurse education on the local SEMSA guidelines. This involved the data sheet, which is the EDENDALE data sheet, and every patient that comes to this clinic gets that data sheet completed by the attending doctor. And part of this was to make sure that every patient was seen in a structured and comprehensive manner. The other reason was purely to make sure that a copy of this is now sent down to the patient's local clinic. So we're now disseminating information from the regional level right down to local clinic level, where most of management decisions are made. The second was the introduction of a diabetic data stamp, which every patient at the clinic now gets done as soon as they arrive at the clinic. This ensured that the sisters that see the patients gets their height, weight, body mass index, waist circumference all done, together with sugars, urine dipsticks, and blood pressure sitting and standing. The information is then sent to the doctor with the patient, and the doctor or the attending clinician can then make decisions based on what he's finding there. The third innovation that we've introduced at the clinic was a specialized computer program that was designed by myself and a data programmer to encompass all the variables that we are finding on this data sheet. And this program is very specialized. It will be able at the end of it to compare variables, whether we're comparing clinical or epidemiological variables to biochemical variables and vice versa. In terms of long-term gain, we're looking at the fact that by controlling patients' blood sugars now, blood pressures, overall glycemic control improves. When you control overall blood sugar, you decreasing the incidence of complications in these patients. This will then translate in the long term fewer diabetic complications, less needs for amputations, less need for dialysis and coronary artery bypass graft.
The name of the project is Procurement Plan System, referred to as PPD. During the previous years in the department, there was no web-based system in place. SCM has been using MS Excel, thereby resulting the institutions and districts submitting their procurement plan via USB to SCM head office. As a result, this cost the department thousands of rands for that exercise. The system is a web-based. It allows accurate consolidation of the procurement plan captured at head office and institution level. This provides a seamless transfer of data from institution, district to head office because the information is in real time. This web-based system has dramatically reduced operational expenditure, especially because it automates the collection, aggregation data into a database for SCM official to use. A similar system in the market cost over 1.5 million, excluding maintenance and licenses fee. I took this initiative to develop a web-based procurement plan, and it is a first web-based procurement plan in the province, and it is also only few countries in Africa that have a web-based procurement plan. I was just one of the dedicated employees that I said, let me do something that the department will be proud of, and the department will save over 1.5 million instead of going out there to a service provider and spend the money. I decided to come up with this innovation and save the money, and then the department can then use the money elsewhere to save the patients' lives.
We've been going through a severe drought in the Harding area, the Simzua Bantu area. And what was going on here is that the dams dried up in Harding, and we had to have tankers coming in to give us water, right? And so we sometimes went without water for like 2 to 3 hours waiting for the tankers. And so I looked at the the 2 boreholes that were closed for something like 50 years. And I went in there, I got an expert to have a look at it, and we decided to get the balls running again. Prior to this, when the municipal water shuts off, right? No one knew when the municipal water shut off. So the whole lot of the water in the institution would get completely empty, right? And then we'll have calls from the kitchen, theatre, laundry to tell us that, you know what, we've got no water. Then we go up to our tanks and it's empty. So later on, I decided, no, we have to combat that, with the early warning system. When the water runs out, when the municipality stops the water, that light will come on, right? And the siren would kick in. So everybody knows that there's no water from the municipality. This is the first borehole system that we started, okay? And we've put in a new borehole pump, right, complete with the electrics, right? And this pump here, when we tested the water was good for human consumption, but it wasn't, it would have affected our machines. So we had to remove like the iron and manganese from the water by using this device here. And this is what pressure we have. That's the pressure that we have here of water. And all this water is from the borehole. The water fills in there into the tank, and from there it can either go through that system there straight into the line to the hospital, or we can just go via the normal system that we are using. And that's exactly what we are using, because there's a lot of pressure that comes from that side. So we actually fill this tank and let it work normally. Moving forward, because our laundry is the biggest consumer of water, we are now busy trying to recycle that water from the laundry. And we've just had a technician come on, and now at the moment this morning, and he had a look at the site where we're going to plan to do this water recycling. And then from there we'll use them only for our flushable toilets. And nowhere else, not even for wash basins and all that. It's just going to be only for flushing, because it's going to be purified water.
The PILLAY project, it's all about home deliveries. We do home deliveries. We deliver medication for those patients that are unable to go to the clinics or are unable to come to the hospital because they are bedridden. Some of them, they are blind. They cannot stand long queues. So we help them out and go to their houses and deliver. Mrs. Ludwig, our boss, or my manager, she is the one who came up with this project of the safe disposal of injections, because we've realized, she has realized that the patients are unable to dispose those injections safely. So that helps that those injections, when they come back to us, then we can dispose them safely. Because some of them, what they do, the patients that is, they put them in their rubbish bins. They get up being, you know, thrown into the streets, and that is a danger. We've got the SHEPS containers that we would give to the patient. And then we will explain to the patient how the SHEPS container works and how full they must fill it, you know. So normally, based on the units of the insulin that they are taking, it would mostly take the patient about 3 months. So we tell them that they must keep that container for 3 months, and then in 3 months' time they must bring it. So on a monthly basis, as we see the patient, we ask them how far full the container is. Then once it is full, the patient will bring it back to us, then we replace them with another one. And then also we let them sign to indicate that they received a new one. This is what it looks like. These are the containers that we give to the patients. They're already full, as you can see, like this one. This is a makeshift one. because now we had these ones, we had to buy them, but we ran out of the budget, we ran out of money. Then we had to use these ones. This is our water bottles for the patients. And then we also give the patients pamphlets like these, just to educate them furthermore as how to do the safe disposal of injections. And also Mrs. Ludwig has designed a board like this that we have to take to the facility every time. It shows the patients, as it teaches them how to do a safe disposal of all these injections. Then there's another one at the back as well. This is just also teaches them how to take their medication. But the most important one, like I said, it's the other one that has to do with the safe disposal of all needles. Because it has this, this top here that you can actually open it from the top here like that. But in the inside here, it is made for the patient to insert the needles in there. So it is very important for the patients now. They don't have to worry anymore, because now you understand they have to worry about taking the medication. They also have to worry about how to get rid of all these needles. Remember, there's people that are using these needles. They're using these needles to inject drugs, So if they get them lying on the street from the rubbish bin, it's easy for them to use them. But now if we're getting them back, then at least we're saving the world, you see. There it tells you not in the trash, like these are the rubbish bins that I was talking about. They mustn't put that in there. Instead, we give them that, they must bring it back once it is full for us. So I think it's a very good initiative for us. As a team, we do get job satisfaction with all these projects that we have outlined. It helps us a lot. We get to build a strong relationship between us and the patients. We get to know what the patient's needs are, and we go back to our manager, Mrs. Ludwig, to try and explain to her what is it that we can do to try and improve the patient's needs. And then also it is very exciting to go out and see how the patients are doing. You go to bed to sleep very well knowing that you've helped somebody, not only health-wise but economically, because these patients have to spend money. Those that are on wheelchairs and are bedridden, for example, when they get somebody to take them to their nearest clinic or facility, they have to hire a car for them. So it's money for the person that is hiring the car for them, and for the patient themselves to and from the facility. So if we go to them, it saves them money too, so it is really helpful.